Welcome to today's session of the Global IPC webinar series. We're happy to be reconvening again in 2021. My name is Katie Wilson from the US CDC, and I help to coordinate this webinar series. I'm an epidemiologist with the International Infection Control Program. In these first couple of minutes, I'm going to go through a few reminders as we get started with today's session, which is on delivery strategies and infection prevention and control, or IPC, for COVID-19 vaccination. This webinar is being translated live into Arabic, French, Portuguese, Russian, and Spanish. You can click the interpretation button at the bottom of your Zoom menu to access the interpretation. If you have any questions during the webinar today about the topic or IPC, please use the Q&A box and a team from CDC and WHO will be answering questions. If you have any questions about the webinar series or technology or logistics, please use the chat box where our colleagues from Project ECHO will be monitoring the chat box. This session is being recorded in all of the languages, and your attendance is consent to be recorded. The slides and a link to the video recordings will be on the Project ECHO website in a couple of days, and we will put this hyperlink in the chat box. There will be a certificate of attendance available for this session, and that link will be in the chat box at the end of the session if you would like a certificate of attendance. And lastly, Project ECHO and CDC does use the participation data to help improve programs and keep these webinars running, and so we thank everyone for your participation. And with that, I will stop sharing my slides and hand the microphone over to Dr. Benedetta Allegranzi from the World Health Organization, who will be chairing and moderating today's session. Over to you, Benedetta.
Thank you very much, Katie. Happy New Year, everyone. Thank you for joining again our webinar series. Today, we have a very interesting topic. I would like to specify again that this session is talking about delivery strategies and plans for the COVID vaccines, but it has a focus on infection prevention and control. So I know from the questions that participants submitted to the system that many of you are interested in also other aspects related to the vaccines, such as efficacy, effectiveness, and adverse events. And I'm not sure we will tackle into the details these issues today, but I would like to announce that WHO will work with the ECHO project to deliver a series of webinars and presentations on the vaccine in different areas, in particular country readiness and delivery. And so you will have the opportunity to really listen to many more details and ask very specific questions related to the vaccine and its delivery. So as I said, today we mainly focus on infection prevention and control, but we have a very dense agenda. We have initially 4 presentations, short presentations, 2 of which, the initial 2, which will talk about strategies, planning, approaches, and also initial lessons learned for the COVID vaccines delivery. And then 2 presentations on infection prevention and control in particular. This will be followed by a question and answer session moderated by a colleague of mine, Carol Fry, who will ask 4 panelists questions. And these questions build upon also some of the questions that you have asked in the system. As usual, we will have polling questions between the speakers' presentations, which Carol will ask, and you will have the opportunity to vote for. So with no further ado, I would like to start to introduce the first speaker, who is my colleague Diana Chang-Blanc, who works in the immunization program operations at WHO. And she will present on the WHO's role and strategy for the COVID-19 vaccination, including delivery plans and the COVAX approach. Over to you, Diana. Diana, I'm afraid we can't hear you. You just need to unmute and put your slides on the screen. We can see the slide. No
Terrific.
problem.
Apologies for that. I couldn't find the mute button. So greetings, everybody. My name is Diana Chang-Blanc. I work for WHO in the immunization department. In the short time I have, I will introduce you to WHO's role in the COVID-19 vaccine delivery under the COVAX facility. So the endeavor is quite a challenging one. Historically, in terms of vaccine introduction, here is a graph of all the different vaccines that are used by our member states and the trend line between 1990 to present of how fast all member states introduce a vaccine. And the most recent example we have is of the inactivated poliovirus vaccine, where all member states were successful in introducing that vaccine in a timeline and a trajectory of about 4 years. And with the COVID-19 vaccine, we're talking about trying to accelerate that introduction for all targeted populations in a period of 2 years. So it's quite an ambitious agenda. To date, we have about 55 countries that have so far introduced COVID-19 vaccines. Here is a graphic from the One World data, Our World Data website that shows you that these are the top 10 countries that have so far introduced COVID-19 vaccine, the highest ones being United States and China in terms of the number of doses administered. This is not the number of people immunized because some of the vaccine products require 2 doses. But about 45 million doses have been administered so far in 10 countries, with the earliest introductions being in December by Russia and the UK. And currently we have 5 different vaccine products on the market using 3 different vaccine manufacturing technologies. Sorry, my screen is frozen. Okay, there we go. So the ACT Accelerator is a global structure to work on the collaboration for the accelerated development, research and development, production, regulation, and manufacturing of vaccines, therapeutics, and diagnostics. So here is a graphic that shows you all the key partners that are involved in the ACT Accelerator with the objective to reduce COVID-19 mortality and severe disease and put an end to the acute phase of this pandemic. And as of this morning, we were informed by the new administration of the United States that the United States will also join the ACT Accelerator. So we're very pleased and delighted about this development. The COVAX facility is the vaccine pillar of the ACT Accelerator. Its specific goal is to accelerate the development and manufacture of COVID-19 vaccines. It is co-led by Gavi, the Coalition for Epidemic Preparedness Innovation, CEPI, UNICEF, and WHO. It supports the largest actively managed portfolio of vaccine candidates globally, and its key objective is to deliver 2 billion doses of COVID-19 by the end of 2021. In the COVAX facility, there are 190 participants. 98 of them are high-income countries, and 92 of them are part of what's called an advanced market commitment. These are low-income countries or low-middle-income countries that are eligible for donor support. And the 2 billion doses by the end of 2021 are targeting 20% of populations in those 190 countries. Underpinning all the WHO guidance are materials developed under the endorsement of our strategic group of experts, SAGE, and WHO has launched a 3-step process for program strategy. So the cornerstone is the values framework. This was issued in September. There's a hyperlink in the box on the left, and it outlines general principles, objectives, and priority groups for COVID-19 vaccine. Principles such as well-being, global and national equity, or reciprocity. Building on the values framework is the prioritization roadmap, which was issued in October. And this outlines the priority groups for vaccination based on the epidemiological setting, whether it's a cluster of cases, no cases, or community transmission, or even sporadic cases, juxtaposed against the vaccine supply scenarios. And this prioritization roadmap will be further evolved and developed as the vaccine supply picture changes. And lastly, there are vaccine-specific recommendations based on market authorized vaccines as they become available that are very defined around the vaccine product characteristics. So for instance, the SAGE recently came out with a statement on the Pfizer vaccine. So there is recommendations around the use case for the Pfizer vaccine. So for the country readiness and delivery workstream of COVAX, it is quite a large endeavor. You see a number of working groups that are focused on different areas of delivery. And the country readiness and delivery group tracks globally what is happening in terms of countries' readiness on different elements in terms of preparatory steps and implementation readiness to roll out a COVID-19 vaccine. And at the bottom of this graphic is a link where you can see the dashboard and how that is updated on a daily basis. The Country Readiness and Development Team has also guidance for a national deployment and vaccination plan, which guides national governments in terms of developing their strategies. And it builds on the existing documents I spoke about earlier from the state endorsed by the Strategic Advisory Group of Experts. There's a link at the bottom of the page. And in that guidance document, which covers 12 chapters, it runs through best practice recommendations from regulatory preparedness, planning, and coordination, all the way to COVID-19 surveillance and post-introduction of COVID-19 vaccines, running through the elements of implementation in between, specifically on the target populations and the defining strategies for those target populations. And that document is also available, not just as a document, but as a training set in the hyperlink here on this page, Orientation to National Deployment and Vaccination Planning for COVID-19 vaccines. There is a website that's open to all that you can go through modules yourself for self-learning or to download those presentations yourself if you would like to be using them to brief others. And also there is a COVID-19 vaccination training website for health workers developed for frontline health workers, consists of 6 modules, including videos and quizzes and interactive exercises. And again, the hyperlink is at that blue line at the top of the page. So lastly, the two documents I spoke about are quite general, cover overall the activities around COVID-19 vaccination, but of course, every product has very specific characteristics. So in addition, WHO has developed vaccine product-specific training resources geared towards health workers. So this is a copy of the Comirnaty Pfizer vaccine. It's a job aid that can be used and is also available on the site that I'll show on the last page. And they include short instructional PowerPoints on vaccine management and handling for this vaccine. And these vaccine products sheets will continue to be produced as additional vaccines come online and are authorized by WHO under the EUL. This is my last slide. We've also opened up a general help desk. In the red there, you see the link. You are welcome to email if you have any questions. We have a team of people that are responding and fielding those questions, whether they're vaccine specific or whether they're regarding COVID-19 vaccine implementation strategies. So on that note, I'd like to thank you very much for your attention.
Thank you so much, Diana. Thanks a lot for your informative presentation and also for keeping on time. So I would like to remind the participants that they can ask questions in the Q&A chat or session, and the speakers are kindly asked to answer questions in that Q&A chat during this webinar. And it's my pleasure now to introduce the second speaker, Dr. David Fitter. He's the co-lead of the Vaccine Task Force at the US Centers for Disease Control and Prevention. And he will present on considerations and lessons learned in rolling out the COVID-19 vaccination program, the US perspective. Over to you, David.
Thank you, everybody. And let me share my screen really quickly. There we go. Good morning to everyone, and thank you for having me. I really appreciate being here. Recognizing I probably have too many slides, I'll jump right in. So this slide was, it's a day old, and I think Diana touched on some of our numbers here, but this is something that we publish every day with regards to total doses administered in the US, and then breaking down the doses as well between those receiving 1 or more doses and those receiving 2 doses. I think, again, as Diana said, looking at the variety of vaccines that will be implemented in the United States, we wanted to take this into consideration, and certainly we'll be examining this as new vaccines get introduced. I think everyone is very familiar with this, but this is sort of our standard slide that we use when we're talking with a lot of partners. These are the 2 vaccines that we are currently using in the United States. We first introduced Pfizer, and then a week later, Moderna was introduced. Certainly, aspects of this that I believe everybody is examining are the logistics and cold chain considerations for both of the vaccines, which have been interesting to employ, but it has been, I think, successful as we've rolled it out in the United States. We broke our COVID vaccine deployment into phases, and this was considerations from the Advisory Committee on Immunization Practices, or ACIP, and then it was employed throughout the US. Just for everyone's consideration, the United States is broken into 64 jurisdictions when it comes to immunizations, and so each of them put together plans to deploy the vaccine in their jurisdiction with support from the CDC and other federal partners as well. So you can see here in phase 1A in dark blue, we had healthcare professionals and long-term care facilities, or LTCFs. In phase 1B, is 75 years and older, as well as frontline essential workers, and I'll touch on that a little bit more. And then phase 1C in a lighter blue, which is the 65 to 74-year-olds, other essential workers, and 16 to 64-year-olds with high-risk medical conditions. And then shifting to phase 2, which is 16 to 64-year-olds without high-risk medical conditions. You have some of the population numbers that were enumerated for that, so quite a large population. Again, I just want to emphasize, as we were rolling this out, the ACIP recommendations are that. They are recommendations. Jurisdictions were also looking at the epidemiology of disease and their populations as they develop their plans. And so if one looks at sort of the jurisdictional plans and the rollout of vaccine in the jurisdictions, you'll see that there is some overlapping between the phases, which was expected. So a little bit more about essential workers. We look at frontline essential workers, which is approximately 30 million people in the United States, and then other essential workers is about 57 million people. This list was developed based off of research that was done by another federal agency called CISA or CISA, also in collaboration with ACIP. They were looking through this, they were looking through other documents with regards to essential workforce, and they provided this list to jurisdictions to help them in the selection of their populations. I think as everyone is aware, even as we look at the phases, 1A, 1B, 1C, that there does need to be sub-prioritization within those phases. And then how do jurisdictions do that? And so we spent much of the fall having these conversations as well as the jurisdictions were looking at their populations. This is a brief representation of the distribution and administration strategy. So in the early phase of the distribution, we recognized there would be limited vaccine. So COVID-19 vaccines were administered focused areas for priority groups, healthcare personnel in the long-term care facilities for the residents and also for healthcare personnel there, and also through public health clinics. Now, as the distribution continues, expanding the number of sites that can administer the vaccine, thus to the broadening populations within the different phases. One of the underscoring themes for us was ensuring equity and expanding access. On the right in the darker blue, you could see as we begin to expand that we're using other points of distribution or pods, as we call them, throughout the US. Pharmacies will play a large role in what we have done for our vaccine rollout. I don't think I need to go too in depth for this, but some of the complexities, as I said before, are the varying cold chain requirements, the need for socially distanced vaccination practices, sub-prioritization of the populations, the dose series, also vaccine efficacy and adverse event profiles. You can see the reactogenicity post-vaccination. Safety monitoring is very key to our program, and then communication and education. We are also looking at some special considerations and challenges for vaccination of essential workers. There's a large number of frontline workers in the US. Also, we spoke already about the need to sub-prioritize for vaccinations. The issue of workers may work in one state, but live in another state. And so the conversations around that, and then coordination and planning for if, where, and when staff are eligible and can be vaccinated. Also, there's a transient workforce that may have difficulty getting the second dose. So all of these were taken into consideration. And then sort of continuing the safety, there's concerns about safety. We want to ensure that the culturally appropriate vaccination information. Rural areas are of big concern, access issues, and then methods of communication may be different as well, using radio, print, local community engagement as well, which has been extraordinarily important. And then some missed days may occur post-vaccination. So working with the commercial communities as well as Chamber of Commerce to try to get that message across to business leaders as well, is they are a part of this vaccination campaign and we need their help. Some of these sub-prioritization considerations I've spoken about, the epidemiology, the knowledge of currently available vaccines as well. Also, we are considering the additional vaccines that might be authorized, and these considerations will continue to be updated. I spoke a little bit about transitioning between phases, and this strategy for transitioning looks at the supply increase and also trying to maintain demand throughout. I think this is a big one that a lot of countries are focused on, is that we want to maintain strong demand throughout this and ensure that we're communicating well with the population about when they will be eligible for their vaccine and how much vaccine there is. There are supply constraints around it. But there is sort of in these phased approaches, there is overlap. I just want to underscore that again. There is overlap between the phases, and one can see that in the different jurisdictions. And some of the criteria that jurisdictions have been using and that CDC has been discussing with them is that demand in the current phase appears to have been met. For example, appointments for vaccination are less than 80% filled for several days. The supply of the vaccine increases substantially. Most people in the current phase are vaccinated, for example, over 80%, or the supply at a certain location is in danger of being unused. One of the other issues is vaccinate with confidence and sort of vaccine confidence overall. So the overall acceptability of COVID-19 vaccine in the US is moderate. It has actually increased since the summer. You can see in the left some of the factors that we're taking into consideration for acceptance and also how to make it more acceptable. I think many people are familiar with the vaccine demand continuum and many questions have arisen. I think the wait and see approach is common. We've seen that in a lot of healthcare workers as well. And I just wanted to spend a second, and I'm probably hitting my time shortly, with regards to our vaccinate with confidence strategy. It's really focused on 3 areas: reinforcing trust, empowering healthcare providers, and engaging communities and individuals. I probably went too fast, but did want to make sure that I gave enough time for everybody else. And so I just wanted to say thank you again for having me here.
So
Carol,
Carola,
I think you are on mute.
Apologies, colleagues, I had problems unmuting. Good afternoon. My name is Carol Fry. I work with Benedetta at WHO. We're just going to have some polling questions, 2 questions, to really see what our colleagues' experiences around the world. So the first question is, are you familiar with or have you been involved with drafting your country's national vaccine and deployment plan for the introduction of COVID vaccine? If delegates can please vote now. So I'm looking to my technical colleagues. I can't see any votes on screen. I wonder whether you can help here.
The polling is going on.
Okay, so I think we can stop there now and see the result of that poll. Thank you. So it seems that a 60-40 split of people who have, so 40% of people have been involved at some level with the national vaccine deployment plan. And I'm sure this will change if we polled again in a few weeks' time as vaccine is rolled out globally. Could we have our next poll question up, please? And this question is to really build on David's presentation. It's really to understand the highest priorities in your own country in terms of vaccination, and can you check all to apply in your country? So health workers, older people, person with underlying health conditions, essential workers, social employment groups, you don't know, it's none of the above, or this has yet to be decided. And if you can vote, please. Thank you. Just give you a few more seconds to decide which boxes to check. And then if I can ask ECHO colleagues to put the results of that poll up on the screen, please. So 91% of countries have prioritised health workers, which I think is very encouraging. And again, there seems to be a lot of consistency in approach, older people and people with underlying health conditions, and then of course essential workers. And as David said in his presentation, it is quite difficult to understand and to which of those essential workers require vaccination. So we finish with that poll, and I get to hand back to Benedetta to introduce the next speaker. Thank you.
Thank you, Carol. Thank you everyone for voting. So it's my pleasure now to introduce Dr. Mitch Schwaber, who is Professor of Medicine at the Tel Aviv University and Director of the National Center for Infection Control at the Israel Ministry of Health, and also one of our key experts contributing to IPC guidance for COVID-19. Actually, he's one of the chairs of this expert group. So I'm very happy to say that he will explain his experience and guidance in his country on IPC during the COVID vaccination. So the title of his presentation is the COVID vaccination program in Israel with a focus on IPC practices. Over to you, Mitch.
Thank you very much, Benedetta. Let me just get my screen share up here. Okay. Okay, can you see my screen?
Yes.
Are you seeing? Okay, great. All right, well, thank you very much. It's a pleasure to be here. And we'll jump right in. A little bit of background about Israel. It's a country of 9 million inhabitants. The Ministry of Health is the central regulatory health body. It has jurisdiction over all healthcare institutions, and it formulates vaccination policy and regulates distribution nationwide. There is universal healthcare coverage for all citizens. Everyone belongs to one of 4 health funds that administers healthcare. So a bit about the COVID-19 outbreak in Israel. We've had 3 waves of infection, an initial early wave dwarfed by 2 subsequent huge waves. We're now in the throes of a 3rd wave that's just now hopefully showing some signs of leveling off and flattening the curve. But we've had over 578,000 deaths, infections, excuse me, with 4,179 deaths attributed to infection as of this midday today. This is what the distribution looks like by age. If you going from the elderly down to the youngest groups, you can see that it's very heavily bottom weighted. Only 12% of the patients infected have been 60 and older. But if you look at the deaths, that flips, the pyramid flips, and over 92% are in the 60 and up age group. Now, looking at the vaccines approved for use, the principal vaccine used to date is the Pfizer vaccine. Moderna has also been approved for use and initially has begun arriving, initially in low numbers. So it's for the moment designated for those who are housebound and unable to come to the vaccination centers. In November of 2020, the Ministry of Health Director General appointed a vaccine advisory subcommittee to set guidelines and priority groups for vaccination. These are the priority groups. They've been updated on a number of occasions, most recently yesterday. But you can see in the groups earmarked for priority vaccination, there are a lot of the groups that we've already seen and we've come to expect to be in the priority groups. We initially started among the general population at 60 and up, but that's gradually we've been able to decrease that to 40 and up. And the most recent addition has been pregnant women due to some recent very difficult cases of severe infection in pregnant women. We're hoping to be able to open it up to additional medical risk groups in the near future, and shortly after that to the general population. So the rollout officially began on December 19th on live TV in prime time, where our prime minister was vaccinated, and immediately thereafter, followed by the health minister. People trained in infection prevention and control might notice a few things here. First of all, aside from the fact that the prime minister is unmasked, that his personal physician and the nurse injecting the health minister are both without gloves. And that's because in Israel, we adhere to the WHO glove use pyramid, and gloves are not indicated except for contact precautions in IM injections. So we advocate for hand hygiene, but no use of gloves. What are the IPC principles that surround vaccination? So we divide this into before, during, and after vaccination. Before vaccination, we have to properly choose the venue and insist on qualified, trained staff. Only the asymptomatic are permitted there. If you're sick, stay home. If you're in quarantine, stay home. Come back after you're done with your quarantine. At the venue, you should be masked and adhere to distancing guidelines. During the vaccination process, the vaccinator and the vaccinated wear masks. There is strict adherence to aseptic technique with all that entails, and hand hygiene as noted by the vaccinator, no use of gloves. After the vaccination, in the immediate period, a 15-minute observation period at the vaccination venue where distancing is adhered to. And in the intermediate period, meaning when you go home until you attain the status of fully vaccinated, there's no change in your behavioral guidelines. You still must adhere to all of the masking and distancing guidelines. And long-term, which begins on the 8th day after the second dose of the Pfizer vaccine, then you attain the status of vaccinated, but there's still no change in behavior in the public domain. You still have to adhere to masking and distancing guidelines. But if you get exposed to a actual case, a confirmed case, that no longer requires you to go into quarantine as long as you're asymptomatic. This is what a dedicated vaccine site looks like, individual stations for people to be vaccinated. This is a workstation with all that you need to adhere to aseptic technique. And there is a computer to enter and document the vaccination in the patient's online medical record. You note the absence of gloves. Those who choose to use gloves may do so, but it does not replace hand hygiene. You must adhere to hand hygiene guidelines in addition to gloves use, should you choose to use gloves. This is a hospital vaccination site at the hospital where I work. Behind this barrier are the vaccination stations. And here there's a dedicated lobby where chairs can be spread out for the pre-vaccination and post-vaccination observation periods, and distancing can be adhered to in this room. So this is our vaccination status as of this morning at 10:35. The dark green represents the first dose, the light green, the second dose. The total number of vaccinated, we're at approximately 2.4 million. You can see 3 weeks after the launch of the first dose, we started vaccinating with the second dose. At the time that you complete your first dose, you're given an appointment to come for your second dose at the same spot. This is the percentage of the population vaccinated. We're currently at 26% of the population having received at least the first dose. The daily number of individuals vaccinated, and you can see that we're getting into the second dose now, as well as new people coming for the first dose. And we're now at, the last few days, over 200,000 a day. And this is the percent of each age group vaccinated. And remember the high death toll in the over 60. So you can see that in the 70 and up, we're over 80% who've launched the vaccination process. And in the 60 to 69 group, we're at approximately 70%. So for the highest risk groups, we're doing well in terms of vaccine uptake. So how have we done it? Well, 2 weeks ago, an article appeared in the Jerusalem Post listing 9 reasons why Israel leads the world in vaccine distribution. Quickly running through them before concluding. One is universal health care. I can't overstate the importance of having everybody covered by a health fund and everybody insured in Israel. Second is people really put trust in their health funds. And there's a big focus on the health funds and nationally on preventative care. We know emergencies. We're well versed, unfortunately, in emergencies and threats to public safety. So we know how to do the drill and to mobilize our forces when public safety and public health are in jeopardy. A lot of people work for the health funds. There's no shortage of manpower, and we've even had a mobilization of volunteers, healthcare workers who have volunteered their time and expertise for the vaccination effort. This is not the first time the health funds have vaccinated many people. In fact, annually, we have a national flu vaccination campaign. So we've done this before. Data and technology are very upfront, and as we've already seen a picture of the patient vaccination being documented in real time in the computerized medical record. And all patients have an online medical record. Very active and proactive communication efforts, high profile, well-known, well-respected health professionals going onto the airwaves in the mainstream media and in social media, promoting the vaccine, putting pictures of themselves being vaccinated, talking about the efficacy and the safety, and very aggressively debunking fake news and misinformation put out by anti-vaccine groups. And finally, the author of the article talks about the spirit of the people. This is the health professionals and the general public. We're ready for this, we're waiting for this, and we're motivated to get this vaccine drive underway and make it successful. As this officer from one of the health funds quoted in the article, we really, really feel the public was waiting for this like a hope that is coming true. So just in the spirit of documentation, here's me getting my first jab and me getting my second jab. And this is my wife, who is a nurse midwife for one of the health funds, administering one jab among the hundreds that she has given to date. Thank you very much for your attention.
Mitch, thank you very much for that comprehensive view of your highly successful vaccination campaign, something for us all to aspire to, but it shows that where there's a will, there's a way, and things can get done. So that's really helpful. So we now have 2 further polling questions, and these are really concentrating on IPC, building on an issue that was raised by Mitch about glove use. We'd be very interested if the poll question can be brought up. My colleagues at ECHO, please. And the question is, do you recommend the use of gloves by vaccinators for COVID-19 vaccination? If there's a skin laceration all of the time, I'm not sure how the antibiotic question got in there, or no. So if you can vote for that, please. So I think the numbers are stabilising, so we'll end the poll there. So there seems to be a split opinion about whether or not to use gloves. 44% of you think—
Carol, we are not seeing the poll.
Oh, right,
Okay.
okay.
Okay, thank you, yes.
Thank you. So it seems that 44% of you feel that gloves should be used, 22%, that's half of that, think they shouldn't, and 34% in terms of contact precautions. So I think this is something Benedetta will be talking to during her presentation. And if colleagues from ECHO can bring up our final poll question, I'd be grateful, thank you. And this is question 4. And this is about skin cleaning. And this has been an area that Benedetta, myself and other colleagues have been debating a lot in terms of skin disinfection prior to immunisation. So if the skin is dirty, you use skin disinfectants routinely with 60 to 70% alcohol-based solutions. Clean if the skin is dirty, then disinfect, or you have no specific guidance on this. Thank you. I think we'll stop the poll there because the results seem to be stabilising. So routine skin disinfection with alcohol-based solution is by far the largest answer, with 18% of you say you clean the skin if dirty, and 41% saying it's a combination of the two, and only 3% say there's no specific skin preparations. So I'll leave it there and then introduce you to my colleague, Bernadetta, who is the WHO technical lead for infection prevention control hub and task force based in WHO in Geneva. And Bernadetta is going to speak on WHO's guidance on infection prevention control procedures for COVID-19 vaccination activities. Thank you very much. Bernadetta, you need to unmute, please.
Apologies. Thank you, Carol. Thank you, everyone. So I'm going to conclude this speakers session and follow on very well from Mitch's presentation and focus on infection prevention and control precautions for the COVID vaccination activities, according to what WHO has recommended in mainly 2 documents, but also in a training module and through additional documents very soon. So the 2 documents that are displayed are those which have been issued already. Diane already spoke about the first one. The second one is really only focusing on IPC, and it's an aid memoir of 4 pages developed based upon the consensus of our IPC expert group, chaired by Mitch, and also upon consensus by UNICEF and in consultation with our colleagues from the immunization team. So first of all, we want to clarify a number of principles underpinning this document and also the precautions that are recommended. So our expert group really strongly explained to WHO and others that we strongly believe that standard precautions to be applied during any vaccination activity are also valid for COVID-19 delivery, vaccine delivery. And this is mainly because people to be vaccinated are supposed to be in good conditions, are screened for COVID-19, and so there is no reason for applying specific other measures, apart from those which are already recommended to be used in the context of this pandemic. And so, as you may remember, WHO advises on wearing a mask in healthcare facilities in any transmission scenario, in particular in clinical activities. And this is one of the additional precautions that is also meant to be used during the vaccination delivery. Other concepts are that it is really very critical to train health workers in IPC basic practices before they start their activities as vaccinators, in particular for the COVID-19 vaccines, and also to develop and deliver targeted information for the public regarding the IPC measures, in addition to other information related to the vaccine. And I think that what Mitch told us, it's very clear. The massive information campaigns and approach that Israel has led to a lot of successes, as mentioned. As for any vaccination activity, this needs to happen in a clean, hygienic, but also well-ventilated environment, and in particular, this aspect of ventilation, as you know, is important in the context of the current pandemic, accompanied by appropriate waste management and other precautions such as those guaranteeing physical distancing. In addition to these basic principles, we want to also highlight that national guidance and protocols for IPC measures, including those related to COVID-19, should be consulted and adhered to when preparing and rolling out vaccination activities. Our aid memoir includes different parts, and I obviously don't have the time to go into the details for everything, but it's important from the IPC and the vaccination activity management to have a solid phase for preparation and planning, where there are staffing considerations, where local guidance is developed, in particular for IPC, but also for the operations to roll out the vaccination. There is need for some environmental considerations and engineering controls, and it's important to secure adequate IPC supplies to be always available during all activities. In the aid memoir, then, we specify the operational phase where specific IPC measures are meant to be deployed at specific times during the various steps. So, as I said, it's important to develop guidance and SOPs, in particular related to screening policies for COVID-19 signs and symptoms, and also other aspects for staff and individuals arriving for vaccination, SOPs on IPC measures that need to be taken by anyone in the vaccination area, and those which are specific for safely administering the vaccines. Also for cleaning and disinfection, appropriate waste management, which needs to take into account at this particular time when there will be a lot of waste produced due to these procedures, need to take into account environmental friendly treatment methodologies and solutions which minimize both general and medical waste. In the planning and preparation phase, also visual reminders and training materials and information and educational materials for the public are needed. All of this needs to be supported and led by an IPC focal point assigned to the vaccination activities, for developing guidance, for providing training, and also for providing supervision. And from the staffing point of view, it is also very important to ensure an adequate number of vaccinators. As I said, it's important to secure sufficient supplies, in particular of medical masks and other PPE, and then other supplies that are fundamental to IPC, such as soap, clean water, hand washing station, but in particular alcohol-based and rub products, thermoscans, tissues, tools and items and supplies for waste management and for cleaning and disinfection, and physical barriers to set up the spatial separation, the vaccination session areas in an adequate space. And in fact, again, in the planning phase, it's really important to set up the vaccination site appropriately so that IPC practices are enabled by this environment. What I'm talking about is really to have some engineering controls that are essential for COVID-19 prevention and also in general, such as having separate entry and exit points, one-way flow of patients, an adequate space for the screening area, physical spacing of participants and health workers through the use of signage, visual reminders, etc. Vaccination stations that are at least at 1 meter apart, adequate ventilation of the environment, and there are specific requirements indicated that I don't have time to explain. Adequate hand hygiene stations and space also for vaccine storage. Signage, as I said, reminders for all the IPC precautions that need to be reminded. And then adequate cleanability of all areas and equipment, and an appropriate system for waste management, including safe disposal of sharps. So regarding IPC, just to summarize very quickly, many of the things that Mitch has already mentioned and that are also clearly explained in a number of documents and trainings that are listed here that WHO provides. So the key measures are hand hygiene, the use of PPE, the application of safe injection practices and appropriate disposal of waste, and environmental cleaning and disinfection. For hand hygiene, WHO emphasizes on the need for the vaccinators in particular to perform hand hygiene specifically at some moments, such as before putting on and removing PPE, in particular the mask, before preparing the vaccine, and between each person vaccine and vaccine administration. Performing hand hygiene, in particular in the latest indication I mentioned, is really challenging sometimes, and it is certainly facilitated by the use of alcohol-based hand drops, which are readily available for the vaccinator during his or her operations. For PPE, it was already mentioned that, first of all, we remind everyone that PPE are to be used according to standard precautions, following a risk assessment process, and therefore, in general, for these operations, the piece that is very important is the medical mask for the health worker and the medical or fabric mask for the person to be vaccinated. Other PPE are needed on site and need to be really readily available for use. For instance, if they are needed when dealing with vaccine adverse events, also in any situation where exposure to non-intact skin or blood or bloody fluids are a possible situation. And also if there is a suspected case of COVID-19 at the screening moment. And for these various situations, gowns, gloves, medical masks, which are already available, and eye protection need to be readily accessible. The use of mask needs to be appropriate. As we all know, there are several steps to be done. And in particular, wearing a mask, putting it on and removing needs to be associated with hand hygiene. And there are different tools that WHO made available, including videos or clippers or tiles and posters. The use of gloves is not indicated for intramuscular or intradermic injections, according to standard precautions that WHO already explained in several documents. Therefore, also for the COVID-19 vaccination, WHO does not advise to use gloves. And they are only indicated if there is any skin breakdown. We want to remind everybody that in general, gloves do not replace the need for performing hand hygiene, in particular between each vaccine administration and for other indications. And the application of alcohol-based hand drops on gloved hands is strongly discouraged by WHO and other institutions. Finally, of course, we need to be reminded important principles for safe injections that WHO has listed in several documents. In particular, I would like to remind you the use of sterile syringes and needles, and in particular, safety in engineered syringes and needles that WHO recommends since many years. Also, there are specific steps in the management of vials, which I don't have time to remind you. And then safe disposal of waste, in particular of auto-disable syringes and needles in puncture and leak-proof safety boxes immediately after use, and key principles of management of safety boxes, such as sealing them and securing them when they are 3/4 full, and disposing them as a separate waste. The same for vials. They should be disposed of in separate containers or waste bags. And if PP is contaminated, they should be disposed as infectious waste as appropriate. The last one is environmental cleaning, where we say that at the vaccination site, we recommend the cleaning procedures to be performed frequently, at least twice daily, with special attention on high touch surfaces, in particular in specific areas, and also minimizing clutter to aid cleaning. So with this, I would like to thank you and hand over again to Carol for the panel.
Thank you, Professor Aligranzi. And we're now going to have some panelist questions, and we're very grateful to the 4 colleagues that have agreed to form part of the panel. I think if you can each introduce yourself when you answer the question. And the first question I have for the panelists is for Dr. Bura. I don't know whether you can put yourself on screen, Dr. Bura. It would be good if you could do that while you answer this question, which I'll read out while we get the technology. And Dr. Bura is based in Jakarta. Oh, thank you, Vinod. I can see you now. So Indonesia, I understand, is one of the first countries in the Southeast Asian region which has started COVID-19 vaccination. We'd be really interested to hear the sort of challenges and initial lessons learned from Indonesia, so colleagues can learn from you. Thank you.
So thank you very much, and good afternoon and good evening, colleagues. Yes, we started our COVID vaccination last week on the 13th of January. And initially we are vaccinating our health workers across the country in all districts, both the private and government health workers. So some of the initial feedback what is coming is it takes more than expected time to vaccinate in the entire process of screening of the health workers, beneficiaries at different levels. We have 4 tables in the vaccination process: registration, screening, vaccinating, and post-vaccination observation. So the time taken is more than the anticipated time. So it leads to at least an hour or more for one person to spend time in the facility. And the second thing we are observing is in health settings, health facilities, it is leading to disruption in other work at that facility. So the routine work of the health facility, people are trying to defer that and not do the routine work. And third thing, our waste management generation is high potentially because we are using a single dose vial at this point of time. So the injection waste and vial waste and the other IPC waste has to be disposed of on a daily basis rather than weekly basis, what was initially thought of in this process. That's it from the first few days of feedback from the rollout in the country. Thank you.
That's really helpful, thank you. And the next panel question is for Dr. Data. So again, thank you for coming to join us this afternoon. And I don't know whether we have the data to answer this question, but people are very interested to understand which lasts longer, immunity after being vaccinated or if getting an infection with COVID. Do we have the data to be able to answer that question? It's Dr. Data. And if you can introduce yourself before you answer the question, I'd be grateful.
Yeah, thank you, Carol. Thank you for, and it's good to be part of this discussion. I'm Siddhartha. I'm the regional advisor to the immunization unit here, the Vaccine Preventable Diseases and Immunization Unit in the WHO Regional Office for Europe in Copenhagen. Thank you. So thank you for that question. Actually, it's we will not be able to have a definitive answer to this question at this point of time. While whether there's an immunity or the duration of immunity after vaccination is yet to be seen, yet to be documented. Also, the same applies for concrete evidence on immunity following SARS-CoV-2 infection. There are several papers which have been published and the media news that we hear. I think it needs to be looked into much more closely and with all the evidences in hand before we can make a very concrete statement around the duration of immunity being provided both on SARS-CoV-2 infection and also the vaccination. So I think as we say, the unknowns around the COVID-19 is far more than the knowns. So this is one entity which falls into that category. And I think we will have to all keep this on our parking lot for the time being and continue with the non-pharmaceutical public health measures, which we all have on our hand and which has proven to be the most effective one. And the vaccine is the new kid on the block. Thank you.
Thank you very much. And I think that takes us very nicely to the next question for Mitch, because I think you touched on this in your presentation, Mitch, that what strategies could be deployed to so that health workers understand that whilst we have vaccination, that's really welcome. How can we get health workers to understand they need to continue with these non-pharmaceutical interventions, all the IPC precautions that Benedetta's described, because I think there's a little bit of COVID fatigue out there. How do we keep the energy up so people comply? Have you any experience from Israel to share with us?
Sure. I mean, it's an excellent question. It's very relevant anywhere IPC is being done around the world, which is everywhere. And I think the short answer is the same strategies that we've been using all along in the IPC community to convince healthcare workers to do the right thing, to behave properly. And I would divide it into two types of information. One is the standard IPC practices, which have, irrespective of a vaccination, meaning a proper adherence to hand hygiene, which has received a lot of spotlight, thankfully, during this era. It's one of the positive byproducts of the COVID era, the attention given to proper hand hygiene, cleaning and disinfection, adherence to standard precautions. These are all universal requirements, irrespective of vaccination and not specifically related to COVID. So I think that we have to maintain the ongoing vigilance and education and guidance that we've been doing all along. That's part and parcel of what we do. The second part is, what about the specific COVID-related guidance? The need to continue to mask, the need to continue to distance, the need to pay appropriate attention to ventilation and to avoidance of crowds. This is a tougher issue, but I would say I do it again with a lot of explanation, a lot of education, and clearly delineating what we know and what we don't know. We know that the vaccine is very effective in preventing disease. That much we know. But we don't know whether the vaccine prevents contagion and the ability to transmit the virus. The other thing that we have to say is that we're building this a vaccinated society up from nothing. It's not like measles vaccine where the population is vaccinated and we just vaccinate the newly born entering into the world. Here we're starting from zero. So it's going to take a while. And in the meantime, even though we may be vaccinated and our patients may be vaccinated, we're still in a situation where the majority of the society is not, and the virus is spreading. And even if we get to ideal levels of vaccine uptake, because we managed to do it, there's still going to be the youth who the vaccine is not yet indicated for them. So therefore, because we still don't know whether the vaccine prevents transmission, and even if it does prevent transmission, there's still going to be a lot of people out there. There are, and there are going to continue to be a lot of people out there who will not be vaccinated. We have to continue to be vigilant. And I'll just say in closing, because I saw this question appeared in the chat, how do you convince, based on everything that I've said, why do we allow people who are exposed not to be quarantined? I think that it's a trade-off. We accept that the vaccine is effective in preventing illness, and if you're fully vaccinated, you are protected. And we're willing to let you, as long as you're asymptomatic, not go into quarantine if you're exposed, if you're fully vaccinated. But we're at the same time, we're going to say you must continue to behave vigilantly in terms of masking and in terms of distancing and all the other non-pharmacologic interventions until we have more data to make more positive pronouncements about what we're sure you can and cannot do.
That's really helpful. And I think has been said many times before, this is a marathon, not a sprint. And we've got to keep our guards up for a very, very long time, wherever we are in the system or whatever we do in the system. So thank you for that. So the next panelist is Ana Paula. If you can again introduce yourself for the question. And this is quite a specific question. So it says, if after somebody's had their first dose of vaccine, a healthcare worker had a low risk exposure and a few days later developed symptoms and fever, what would be the right advice in that scenario?
Okay, thank you, Carol, for this question. Good afternoon, everyone. My name is Ana Paula Coutinho-Reze. I'm the Infection Prevention and Control Focal Point at the WHO Regional Office for Europe. And it's a pleasure to be with you here, and Happy New Year. So I think back to your question, Carol, as Mitch say, right? So, we have someone that, received the vaccine. And we have to remember that nobody's getting a silver, vest that will protect you of everything. Infection prevention and control is actually a silver vest that we are looking for, right? So remember, it's not only about personal protective equipment, but it's also about hand hygiene, it's about administrative controls, making sure that you are trained, that you know how to do things, and of course, having engineering and environmental controls in healthcare facilities to ensure that we are all safe at all times, not only during COVID. So of course that we are, in the context of COVID, there is a lot of focus and we cannot, lose this momentum because COVID eventually will be over. Infection prevention and control will remain. So in this question, so we have to remember that those who are getting vaccinated, when they go back to their, daily practice, caring for patients, personal protective equipment, hand hygiene, ventilation, these all remain the same. So in the case that a health worker had a low risk exposure, let's say that, he or she was exposed to a patient, but this person, the health worker, was wearing personal protective equipment, right? So we are, we have to see that there is not even a risk. But if, the health worker, for instance, forgot to wear a mask or to wear gloves or to wear everything. So in this case, we have to, it's not because of the vaccine that our approach on how we assess the risk for these health workers to, of being exposed, this doesn't change. The principles are still the same. So you have to remember that we have to look at how the exposure has occurred. And ideally, in this situation, when there is a high risk exposure, health workers should be, sent home, right, to quarantine. They need to be tested. And, they can only return to work when there is a certainty that they are not positive. Because what we want to reduce spread of transmission. This is one of the many measures we have that we talk about, this very holistic approach that we have to make sure that we all do our part. So if you take the first dose of the vaccine, don't forget, don't become Superman or Superwoman. Infection prevention control is the right tool to keep you protected. Thank you.
That's really helpful. And while you've got the floor, Ana Paula, I think you also just wanted to refer to other vaccinations that we mustn't lose sight of those. Do you want to comment on that now?
Yeah, I have the pleasure to work with Dr. Siddhartha Datta, and I have been, very well educated about, the importance of also the other vaccines that we have, right? We are, all talking about the COVID vaccine, super important. But there are the vaccines that we health workers, we miss the opportunity to take. And this, I think it's an opportunity for all of us to reflect and say, take your shot. Don't forget, we still have measles outbreaks. We are still having seasonal influenza outbreaks. We still have cases of people getting hepatitis B while working. And for all these, we have vaccines. Unfortunately, for a number of reasons, health workers, they are not the best category that has the highest compliance. We are not, but we can be. And I think this is an opportunity for all of us to reflect that, like infection prevention control, the immunization provides, a number of vaccines that are really important, really critical for health workers to protect themselves, to protect their families, and to make sure that we stop transmission. So remember that if you didn't take your shot for measles or for hepatitis B and for seasonal influenza, don't miss the opportunity. Go and get it. Go and get vaccinated. Thank you.
And I think that's such an important message, that whilst COVID's important, all those other things you talked about are also very important. And I think that we've been working on COVID for the last year, many of us, and it's now to redress that balance to make sure other things don't get neglected. So Dr. Bureau, I have another question for you. It's really looking at your IPC practices in Indonesia and sort of building on what Professor Aligranzi said. And also, I think we're interested to know about, is there a role for community health workers in the vaccination clinics in IPC? Be very interested on your views on that, please.
Yes, ever since this pandemic started, we were able to revise our technical guidelines for routine immunization, vaccination, and how to restart vaccination. Since we have community transmission, it's very important to ensure that all the required IPC measures are strictly in place at the session sites and beyond that. We have engaged the local community leaders and have identified volunteers at every session site who help us in crowd management in terms of ensuring that the people who are coming are seated with a social distancing. Since the health facilities do not have such large waiting rooms, so sitting arrangements are made out in open air spaces, and the village volunteers help in that. The volunteers are also putting up hand washing facilities with soap and clean water to ensure all people coming do take a thorough scrub prior to entering, and they have masks in place, and they are briefed a bit on not to get crowded as they enter the facility. So the role of health community leaders is being taken full into account. Another thing that Indonesia did was, in order to show the commitment or appreciation to the community leaders took the first vaccines as the vaccine was rolled out. The Honorable President was the first to be vaccinated in the country, followed by certain prominent figures, the religious heads, the prominent people at subnational level. So that has really encouraged and motivated people to come forward and play an active part in this COVID vaccination rollout at local level. Thank you.
Apologies. And now we have another question for Dr. Datta. And I think, again, this is a question we may not have the data, but people are really interested to know. So if healthcare workers or health workers have had confirmed COVID-19, do they still require vaccination?
Yeah, thanks, Carol, and thanks for that question. So during the last deliberations of the Strategic Advisory Group of Experts on Immunization, when they provided their interim recommendations for the use of Pfizer-BioNTech COVID-19 vaccine, this issue was discussed quite a bit. And let me tell something which we know of at this point of time. The available data from the Pfizer-BioNTech vaccine from the phase 2 and the phase 3 trials indicate that the vaccine is actually safe in people with evidence of prior SARS-CoV-2 infection. So that is what we know. But the added protection of vaccinating a previously infected individual was not clearly established in those phase 3 trials. So just to let the listeners the context that when a phase 3 trial or the clinical trials for a novel vaccine or a new product is being shaped up, not all the endpoints are not always being defined, or you cannot define all the endpoints right at the start. So there will be few of the unknowns that you get to know as you go past. So within that context, the strategic advisor group of experts made some recommendations to people who previously had SARS-CoV-2 infection. I know the question is related to healthcare worker, but I'm sure you would agree that this kind of question can come for anybody else as well. So the recommendations from the strategic advisor group was that vaccination may be offered regardless of a person's history of symptomatic or asymptomatic SARS-CoV-2 infection. So that brings to the other part is, despite the potential of a reinfection, the SAGE went to say that currently available data indicate the symptomatic reinfection within 6 months after the first infection, though is rare, this person with a PCR-confirmed SARS-CoV-2 infection in the preceding 6 months may be delayed vaccination until the end of this period. So when the more data will be available on the duration, this will be re-looked into as a part of the process. At this point in time, this is what the current evidence are available, and then the recommendations of SAGE by the strategic advisor group of experts will be reviewed as more information will become available. More information will become available. Thank you, Carol.
That's really helpful. And now I'm going to hand back over to Spenda Allegranzi, because I gather the questions in the chat box have been very busy, and then Benedetta's been monitoring that and maybe have some further questions for our panel. So can I hand over to you? Thank you.
Thank you, Carol. So we still have 2-3 minutes. First of all, I would like to thank the participants for the many questions they are asking, and remind them, as I said at the beginning, that this session is in particular is on infection prevention and control. So there will be a webinar series from the first week of February, more or less, really dedicated to different topics in the context of COVID-19 vaccine, where other types of questions can be answered. The second point I wanted to make, we also received questions from the participants through the initial registration. We hope that we answered a number of them, I believe so, but just wanted to, there are 2 questions in the field of IPC. One, I'll try to answer it now, and then the second one, maybe asking Mitch his view on this. So the first question has been to provide more details on the ventilation requirements at the vaccination area. So of course, it depends on the type of vaccination area, because as you know, vaccination campaigns can be held in clinics, can be held in other buildings that are used temporarily, can be held outdoor, and so on. So it changes depending on this. What we say is really to ensure good ventilation, either through natural ventilation or look at the ventilation system if it's mechanical within a healthcare facility or another building. So for natural ventilation, WHO has guidance available that you can find in our website. And it basically consists of ensuring that there are airflows throughout the room by opening windows and doors in indoor spaces. And for the mechanical ventilation systems, we looked at specifications from ASHRAE And we agreed with experts that the optimal requirement would be to have at least 6 air exchanges per hour. But this can also be checked, as I said, in our aid memoir. It is indicated where you can find a good reference for this. And also never forget to also consult your national regulations or policies on this topic. So before we hand over to Kathy again, the question I wanted to ask Mitch, which was provided by the participants, is really to clarify whether the waste management from COVID-19 vaccination clinics or activities should be hazardous waste or not.
So I think it really depends on your national policies. I can tell you our view. And there's really three types of waste in these facilities. One is the medical sharps, okay? The needle that has after injection, that goes into the sharps container. I showed it in my presentation, and that should be discarded of safely and as all medical sharps are in a closed container that protects people from risk of sharps injuries, and then is autoclaved and discarded of according to national guidelines for disposable infected sharps. The other second category is anything that's left of the vaccination materials, which hasn't been used but has to be discarded. And I think that there it really comes down to the manufacturer's guidance. And each manufacturer, based on its vaccine, will describe how unused but needed to be disposed portions of their formulations need to be discarded. And then the third element is just the standard gauze pads and wrappers and waste that's generated from a vaccine clinic. Now, keep in mind, the corona vaccination clinics should be the places in the world where there is the least active corona disease, right? Because we're telling people if you're sick, if there's any possibility that you have it, don't come. And so everybody there should really, it's probably the lowest pretest probability to find corona vaccine. So therefore, I would say the waste should be treated as you would treat any of similar waste in a vaccination setting. I know that our policy doesn't necessarily jibe with WHO policy about even in the corona wards. Waste that's generated in the context of standard medical care, we treat as standard waste. I mean, it has to be double bagged. It has to be carefully protected against leakage, but we don't require it to be sterilized before discarding like other medical waste. And I know that's not agreed to by everybody. But at the clinics, since we have that policy for the corona wards, certainly we're going to have that policy for the vaccination sites where there should be no corona.
Thank you so much, Mitch, for giving these explanations. I think it's really important because there have been many questions on this topic and also the discussions for WHO to get to a final agreement on what to recommend in particular for the vaccination clinics required quite a lot of discussion. So thanking everybody, the speakers, the panelists, Carol, ECHO project and CDC colleagues for sharing with us the knowledge and also the organization of this important session, and handing over to Kathy for conclusions. Thank you.
Benedetta, and again, thanks to everyone today for the great
Katie,
speakers.
I don't think your voice is being transmitted properly. Can you try
again? Now?
No. Is it only my problem? Carol, can you hear Kathy well?
She sounds very...
No, her voice is not clear.
How about now?
Yes, now it's better.
Sorry, we will be quick. Thank you everyone for joining. If you would like a certificate of attendance, please click on the link in the chat. And like Benedetta said, there are upcoming webinar series from WHO that we are excited about and everyone can join, and we will stay in touch through the email list. And we will sign off and say goodbye to everyone. Thank you.